Dr.Sreejayan.M.P is currently working as Professor of Surgery and Medical Superintendent at Government Medical College, Calicut. He belongs to the 1985-90 batch of the same college. He completed his post-graduation in General Surgery from Government Medical College, Calicut, and had been working in the Department of Surgery for the last 29 years. He is an expert in the field of esophageal surgery, having been trained from the University of Michigan, USA, under Professor Mark B. Oringer, who pioneered the technique of transhiatal esophagectomy. He also had the opportunity to work with Professor Masahiko at Juntendo University, Tokyo, Japan, and with Professor John Wang and Professor Simon Lau at Queen Mary Hospital, University of Congo. Dr. Sreejayan did his PhD in thyroid diseases from Calicut University. He is a fellow of the Royal College of Surgeons of Edinburgh and Glasgow. He had additional responsibility as an administrator at Calicut Medical College for 21 years in various capacities, and he is the current medical superintendent of the Medical College Hospital. He has made tremendous contributions to improve the infrastructure and patient care facilities at the institute. Dr. Sreejayan is an active member of the Association of Surgeons of India. He was the executive member, joint secretary, and honorary secretary of ASI Kerala chapter. Kerala state chapter received the Best Chapter ASI award on 2 consecutive years in his tenure as the secretary of the state chapter. He is a constant presence as faculty for scientific meetings of ASI at the state and national levels. He has 30 publications on various aspects of surgery to his name. He is a postgraduate examiner for MS, DNB, and PhD in Faculty of Medicine. He is also an examiner for the Royal College of Surgeons of Edinburgh, UK. Despite his busy schedule, he still holds his passion for surgery close to his heart, and patient care is always his first priority. The membership of the ASI Kerala chapter is proud to honor Dr. Sreejayan with the highest honor, the Professor Ragavachari Oration for 2022 on the topic "Failure is Success if we learn from it. My sojourn in esophageal surgery."
Thank you, Dr. J. Now I request the ASI chairman to adorn the Oration Award. We invite Dr. Sreejayan to deliver his lecture.
Dr. Sreejayan.M.P is unable to reach here, but to me, I express my sincere gratitude to Dr. Sreejayan.M.P. He has offered me the first platform in ASI, and subsequently many more platforms in the state and national level in many times. And I think he is the life energy for ASI in the state and national level. Professor Kanakantharan, when he was working at Calicut, he has opened the door for me to join ASI. And I was secretary to the association for 2 years. Professor L. Riku and Professor R.B. Prasad were the chairman at the time. And I had a very good time. And in the initial introduction, Dr. Jain said that we received Best Chapter Award on those 2 consecutive years. When I was a 3rd year student, my first posting was in surgery with Professor K.P. Rajagopal. And on that day itself, I decided that I am going to take up surgery. Impressive personality, the way he talks to the students, even though very low volume, but everything has attracted me, and I had no second thought in deciding my career in future. Professor Sarvodhaman Nedungani, he came back from Kenya after 5 years leave, and he had joined at that time with Professor K.P. Rajagopal. And he has taught the basic things in surgery as a 3rd year student. Professor S.P. Mallar, I received the first surgical knife from Prof. And it is interesting that I received the full load of hydrocele fluid on my face, and since then I was ready to accept all the realities or the difficulties which I am going to face in future. Prof. M.P. had worked at Calicut as head of the department, and I had the fortune to work with him. Apart from surgery, a lot of non-technical skills I have learned from him. The situation awareness, the decision making, and the teamwork, and the leadership, everything I have enjoyed, and we had a very good company. And before going to Rajan sir, I was fortunate to have a lot of teachers from Trivandrum. Even though I was not a student at Trivandrum, I had very good interaction and many teachers inspired me, like Professor Fasil Malika, Professor Dayananda Babu, Professor Karthikeyan, Professor Madhamohan, and so on. Dr. Salim. So many teachers from Trivandrum, Dr. Kalam, Dr. Ishwar, they all influenced in the surgical life. And I have nothing more to talk about this great person. The association or my relation with Rajan sir was right from the start of my surgical career in 1992, and he is my guru. This is my alma mater, Government Medical College Kozhikode, and I have been here for the last 37 years, and all my dreams came true from this great place. I'll move on to the journey in esophageal surgery. Surgery still remains a standard of care in esophageal cancer, but we get a lot of patients in advanced stage. That is the only difference. Nowadays, I am unable to operate a patient primarily. Most of the patients undergo neoadjuvant treatment and then come for surgery. Just few things about history. Franz John Tourette. He did the first thoracic esophagectomy in 1913, and the approach was through the left thoracotomy. That patient survived 12 years, and this is a photograph. And he couldn't connect with stomach or colon, but it was connected with a tube, and that patient survived for 12 years. The transthoracic esophagectomy complications were very high, and then from Australia, he tried several methods, and finally he started transhiatal esophagectomy. But the results were not very good. But in 1931, Gray Turner attempted, and he did the first successful transhiatal esophagectomy. Ivan Lewis in 1946, Ivan Lewis started his procedure, and he has published, or he had operated 7 patients and published this in the Royal College, and has published this article in British Journal. But nowadays, most of the esophageal centers have moved to neck anastomosis, considering the thoracic leak and further complications, and many people are doing only neck anastomosis. But definitely, this was the most popular procedure for thoracic esophageal cancer. Garlock's procedure is an extensive procedure where both rectors are cut, and then it goes through the 7th or 8th intercostal space, dividing the diaphragm, reaching the left thorax. But again, there are a lot of difficulties. The left ventricle will push the hand of the surgeon, and the lung also will be a hindrance. So I also did few procedures with this technique, but I have not found advantage with this, and nowadays I don't do this at all. McVan's procedure, this is as a common procedure, but because of the advent of laparoscopic and thoracoscopic procedures, slowly this is also disappearing. Right thoracotomy and mobilization of the esophagus with the right thoracotomy, followed by laparotomy and neck incision and gastric pull-up and anastomosis in the leg. This is almost replaced by thoracoscopic and laparoscopic procedures. 1997, the early experience in minimally invasive esophagectomy was published, but in 1993, actually, Dr. Palaniveru has started thoracic dissection with thoracoscope. Coming to my journey, I was posted with Rajan sir, with Professor Shankarankuti Varya in 1992 in the surgical unit, where Professor Shankarankuti Varya used to operate a lot of patients with esophagus. But what we have found is almost all cases were advanced, but always used to talk, let the patient eat, let the patient swallow his own saliva. The initial or the patients, the disease is advanced, but patient is unable to eat anything. So investigations were limited, availability of CT scan and further investigations were limited, but sir used to operate most of the cases. Complications were there, leak, morbidity and mortality was there, but the sir's principle can be equated to what we call as quality of survival, quality of life. The quality of life is one should be able to swallow their own saliva, even though some of the patients die. So when I saw all these things, the complications, morbidity, mortality, and poor lung reserve was a big challenge. I had taken me to the doorsteps of Professor S.M. Chandramohan, who was the head of the Department of Surgical Gastroenterology at Madras Medical College. We had a very long association of almost 21 years. And he was a very good teacher, a motivator, and a very good friend. He has taught me a lot of lessons in esophageal surgery, and he's a world-renowned esophageal surgeon. We miss him a lot because last year he sudden sad memories. Mark B. Oringer, Professor Mark B. Oringer was the chief of thoracic surgery at the University of Michigan Hospitals, and he started Oringer's procedure in 1978. In fact, in 1913, then started, and Great Turner continued it in 31. But the procedure which we perform now is from Professor Mark B. Oringer. He has popularized transaxle esophagectomy for almost about 40 years, and he has performed more than 3,000 transaxle esophagectomies. And I had the good fortune to work and learn from him. The originators of three-field lymph node dissection, Professor Akiyama and Professor Masahiko Surumaru from the University of Tokyo. It is a treat to watch the Japanese surgeons operating. They are all organ specific, and one surgeon operates on that particular organ and they perform it very well, and it is a treat to watch. And I've worked with them, and they have popularized the vagus preserving esophagectomies also. But what I have learned from them is, one important thing is, after three-field lymph node dissection, most of the patients' hospital stays very much prolonged. Some of the patients will stay in the hospital for about 72 days. Invariably, the patient will go in for ventilation, tracheostomy, bronchoria, repeated bronchial aspirations. So many problems were there, and I don't know whether the decision taken at that time to operate with the three-field lymph node dissection was correct or not on my side. So I have not continued with the three-field lymph node dissection. Even though the Japanese, they give excellent results world over, and that was not duplicated anywhere in the world. And Professor John Wong, the head of the Department of Surgery, and Professor Simon Lowe, they have written chapters on esophagus in almost all textbooks, main go mastery, and all textbooks, their chapters there. And I had the good fortune to learn video assisted thoracoscopic surgery and thoracoscopy from the University of Hong Kong. The success of any surgery depends upon the selection of the cases, preoperative optimization, and the surgical techniques. If we start operating all patients with esophageal cancer, definitely the results is going to be poor. Assessment is important. We need to assess the tumor, nodal and met status, for which we need endoscopy, barium solo, a CT scan, in selected cases bronchoscope around the lesion is around the carina, and all the investigations are required for proper assessment. A treatment modality surgery is the standard of care in esophageal surgery, but it is a multidisciplinary approach where the patient is going to get a good result. Basically, because chemotherapy and radiotherapy has to be combined in selected cases. And in the last few years, I have not operated a single case primarily. All patients underwent chemotherapy, so their lifespan also increases. Technique and the approach of the approach to the esophagus. Nowadays, the standard of care is thoracoscopic and laparoscopic, but if the surgery is trained in any other methods, that is best for him to proceed. Transaxial esophagectomy also is the best approach in selected cases where if the patient is having pulmonary problems, transaxial is best. And gag kits, mainly we were using clamps and ties, silk ties and all those things for clamping the omentum and making the stomach for the bone view. But now we know that very good energy devices are available like harmonic scalpel or post with which we will be able to perform these things without giving a transfusion after surgery, and the time also is reduced very much. Similarly, we used to suture the stomach for stomach tube, but now we have staplers, everything is over in 2 minutes. So we could reduce the time for the esophageal surgery very much. Anesthesia facilities, especially lung, single lung anesthesia and the post-op pain management and the perioperative care, everything has improved and the results are now much better now. Mortality and morbidity is low in high volume centers. A high volume center is actually defined as a center where more than 20 esophagectomies are performed in a year. And simple thoracoports are available. There is no need for a standard laparoscopic port for thoracoscopy, and I don't use gas or carbon dioxide for thoracoscopy. I use a single lung ventilation with a WM endotracheal tube. And the optics have improved like anything. We have the high definition laparoscopic sets and the 3D laparoscopy with which the perception is excellent, and we will be able to see every areas, especially the corners, the gastroesophageal junction, and the access to the cervical area is much better when we do operate with 3D or 2D scopes. And the same principle is applied in robo also. And robo is excellent in thoracic dissection. I'll be talking about preventing the 3 complications. I'm not going to talk about the management of complications, how to prevent and how to keep the patient alive. Anastomotic leak and stricture, these two are anatomic anastomotic problems, and thoracic duct leak is a corollary because we are doing a thoracic dissection, and part of it sometimes it can happen. So this is a patient.
Hello. Yes, sir.
Actually, that was not an immediate post-op patient. I don't have a video because before 2012 I had leak, and after that I didn't have a leak at all. So this patient, actually it was post-op. You could see a secondary lymph node in the supraclavicular region, and that patient had some dysphagia, and somebody tried introduction of an nasogastric tube and it wrong tracked and it came out through the incision. So that is the way the esophageal leak comes out, and it's a problem for the patient. And but most of the time, if the anastomosis is a wide bore anastomosis, then we will be able to feed the patient with solids but not with liquid. The solids can be fed through the noble tract and the liquids can be given through the feeding the ileostomy tube. Always I started listening to this words from Rajan sir right from my first year, that is prerequisites for safe anastomosis are good vascularity, adequate lumen, and it should be a tension-free one, and the technique has to be good. So if we stick to these principles, I am sure that just like any other intestinal anastomosis, esophageal anastomosis also will perform well. There are a lot of tips for caring the stomach and to avoid leak. The handling of the stomach should be minimum. I never allow my assistant to touch the stomach. I only will handle the stomach. I will not allow the assistant to touch. Because 3 vessels of the right gastric artery. 3 vessels from the right gastric artery is preserved. And the entire right gastroepiploic artery is preserved. And beyond the right gastroepiploic artery, there are no vessels directly supplying to the stomach. So it is purely based on the submucosal vascularity. If we touch the stomach, each time when we touch that area, we will see some vertical hemorrhages happening there. So if we handle the stomach beyond that area, or maybe more than 50% of the area of the stomach tube doesn't have a direct supply. So we have to be extremely careful, and the handling will finally pay for it, as in the form of leak. A 4 to 6 centimeter diameter stomach tube is prepared, and most of the time in open surgery, when I perform a laparotomy, I used to oversew that area only because in the master surgery, in the editorial, it is Professor Mary has written a sentence. Even though I have experience in esophageal surgery for 27 years, I still suture the staple ends because the structures in the thorax are very soft, like pulmonary vein, the posterior part of the trachea, trachealis muscle, that can come in contact with the staplers and it can erode and the patient can have a lethal complication in future. That's a likely possibility. Otherwise, if it is a purely thoracic and laparoscopic approach, there is no need, or we don't do it. And this is the way the stomach tube is prepared. Beyond the 3rd vessel from the right gastric artery, at the incisura, a stapler is applied, maybe 3-4 centimeters, so that the stomach tube becomes straight. And then maybe 20 to 25 centimeters of staple is required. And it is always good to avoid a conical shape at the upper part, so we can hold the upper part with 2 backup faucets so that it will be a straight tube and a uniform tube. You can see that the color of the stomach tube is good. It is uniform from the lower part to the upper part, and there are minimal petechial hemorrhages in the upper part. I cannot say that nobody should handle because we have to hold the stomach at some point. And care of the esophagus, the same way we have to protect the esophagus in the neck. Isolate the esophagus carefully. The guide for the esophagus is the nasogastric tube, and always identify the recurrent nerve. Do not ligate the inferior thyroid artery. Divide the esophagus and take care of the mucosa and avoid suture anastomosis. I will be showing this. You can see the inferior thyroid artery with the branches of the artery going into the thyroid bed. But at the same time, there is a small branch in the lower part which supplies the esophagus. So, never ligate the inferior thyroid artery, which can compromise the blood supply to that part of the esophagus. And second, you can see the esophagus with the umbilical tape, and the recurrent nerve also is there. The recurrent nerve is very important because it supplies to the cricothyroid, and if that is damaged, the possibility for a cricothyroid stricture can occur and the patient can present with dysphagia even though we operate and do the anastomosis very well. And never keep a tube which is suspicious of vascularity when there is ischemia. Always resect that area and do anastomosis only at a good place where the vascularity is good and there are no petechial hemorrhages. If the length is not adequate, we can actually do a cauterization and we can pull the stomach to the neck, because cauterization is generally done when I perform laryngopharyngoesophageectomy. Otherwise, Otherwise, for routine esophageal surgery, I don't do it. If we divide the muscle and the mucosa at the same level, the mucosa retracts. You can see that. If the mucosa is divided at the same level of the muscle, definitely that will retract, and finally we will not be able to anastomose it properly. The mucosa of the esophagus is the most important layer, and that has to be included in the anastomosis. So 10 to 15% of leak is reported in most of the centers, and a modified collar technique it is described by Mark B. Oringer, and it is a side-to-side stapling technique that is the best. And that is the Ivor-Lewis procedure. Right chest is open, and you can see the thick mucosa, and most of the time interrupted sutures or a continuous suture is used for anastomosis, or staplers also can be used. You can see the stomach tube. And here we can do only end-to-end anastomosis. It will be difficult sometimes. If we are using the stomach tube, there is a problem that the chance for reflux is very high, so sometimes a Merendino procedure or in between a segment of jejunum is connected, and then that is anastomosed to the stomach. So this is the neck anastomosis. Here you can see the stomach on the right side, and on right side is the esophagus, left side is the stomach. Enterotomy is placed, and a 4.5 to 5 centimeter of the stapler is applied from the posterior part of the stomach to the posterior part of the esophagus. That is the first stapling. So we have a very good room for the anastomosis. You can see it is a wide anastomosis. We won't be able to get that much of lumen in a patient where we use an end-to-end technique. And another stapler is applied. So actually the anastomosis time is reduced to 2-3 minutes. But otherwise we take at least 45 minutes for the anastomosis here. So overall total duration has reduced very much with the help of technology. And different types of anastomosis can be performed end-to-end, end-to-side, or side-to-side, but the best is side-to-side. End-to-end has a lot of complications. And if stomach is not available, then the next option is colon. But everywhere we talk about the arterial segment, arterial supply, but in colon, it is very important to have the venous supply retained properly. Otherwise, the arterial supply will continue, there will be venous stasis, and if the vein is lost, the entire segment will undergo necrosis, and then once the colonic segment transfer is necrosed, then we have no other option than say dead-end procedure. Stricture is another major complication. The only is that end-to-end anastomosis can naturally cause strictures, but the problem is when there is a leak, it will be seen as an inflammatory erythematous area or an abscess. Once the abscess is drained, invariably this anastomosis will go in for stricture, and in such cases we need to dilate, or we need to do endoscopy and dilate. Otherwise, there is a possibility for stricture. Again, the tips to prevent stricture is avoid end-to-end anastomosis. But it is actually corollary for the thoracic dissection. Generally, I used to isolate the esophagus, isolate the thoracic duct in all cases, and end block dissection of the thoracic duct is done. Once thoracic duct injury occurs, it's a difficult thing to manage, because once you have operated the chest, it will be very difficult to find out because of the post-op inflammation. But in neck dissection, sometimes it happens, then we will be able to enter the chest and ligate the thoracic duct. That is easy. 18% mortality is reported in thoracic duct injuries. General health deteriorates very much. Sometimes inadvertent removal or injury can be there, which can be managed on table, but undetected, it causes pylorothorax in the post-operative period. So what advice is deliberate identification of the thoracic duct. It is something similar to that of rectal laryngeal nerve. You identify the thoracic duct, clip it, or you remove it with the lymphatic tissue. underneath the SIO's vein, in front of the anterior to the esophagus and close to the aorta. Once we dissect and take out the esophagus, we will be able to see it very clearly, and we can ligate it at the gastroesophageal junction. Because of the noise, I'm just playing this. So in all cases, the thoracic duct is identified and it is clipped at the gastroesophageal junction, and the rest of the portion is removed. Japanese used to remove the entire thoracic duct and they dissect the supraesophageal part, and up to T4 they resect, and the rest of the supraesophageal part they take it through the neck when they do the peripheral lymph node dissection. And in the next video, what we're going to see is a leak. It's a deliberate cut. I'm going to remove the thoracic duct, but before that, I just clipped the upper part and divided the esophagus so that we'll know what is happening here. The upper part is clipped, that is towards the neck. You can see the thoracic duct. With the scissors, I'm dividing it. A lot of fluid is coming and it will fill rapidly. And there are different techniques which are described to identify the thoracic duct, but I have not found any, or I have not used. It is easy to identify the thoracic duct when we dissect in that particular area. But just to talk about the statistics, I have operated 396 cases so far. The mean survival is around 35.2 months and 5-year survival is 14%. The longest survival is 16 years. In the last 7 years, including the COVID time, I have operated 149 cases. And it was 80% it was thoracoscopic, transatal it was 20, and I didn't have any anastomotic leak. Always I'm skeptical about talking about this when in a scientific forum when we talk about no leak. I don't know what the senior surgeons are going to tell me, because it is an oration. Probably they may not be asking about this. Still, it's my concern. And I didn't have stricture at all. In Oringer's clinic, there is a stricture clinic and there is a dilated nurse. What they do is they dilate it every 6 days and 7 days off. And next week they dilate it for 5 days, next 4 days, next 3 days like that. And finally, when it comes for one dilatation per week, they send the Maloney dilator with the patient and they do it. And in case if there is a problem, they will come back. And thoracic duct leak, I had one. Even after ligation, some leak, and that patient is still in my ward. And I had death, and that is not due to surgical complication, that is due to pulmonary problem. So success is no accident. It's hard work, perseverance, learning, studying, and sacrifice, and most of all, love of what you're doing. Esophagus surgery, though great stalwarts have attempted in 20th century, success had not been obvious because of supportive care. And it was an area which was not treaded upon even by the middle of 20th century. Advances in the technology, understanding the wound care, intensive care facilities, nutritional support, and anesthesia services has made esophageal surgery look as easy as any other conventional intestinal surgery. I thank the Association of Surgeons of India and Glasg for bestowing me this award. Thank you all for listening.
Sir.
Thank you.
Check. I request all the participants of the debate to meet Dr. Rajat Prasad at the comparing desk.